You're listening to Both Sides of the Stethoscope, where medicine meets the human heart. This podcast is hosted by me, Dr. Colby Salerno, a cardiologist, and my co-host, Dr. Alin and an ICU doctor. What makes our podcast unique? We've both had heart transplants. Join us as we blend our medical expertise with personal journeys, aiming to educate and foster understanding between doctors and patients. From cutting-edge medical discussions to personal reflections, welcome to a podcast that explores the heartbeat of healthcare and the shared experience that connects us all. Let's get on with the episode. Hi, everyone. Welcome back to another episode of Both Sides of the Stethoscope. I'm one of your hosts, Colby Salerno, here with my co-host, Alin Gregosian.
Hi, everyone.
We are coming to you recording on a Saturday night like the cool people we are.
Very cool.
And we, very cool. And we wanted to tackle, I guess, a somewhat controversial topic, but we wanted to tackle the new New York Times article and the topic in it that seemed to gain a lot of attention, especially across social media. Maybe our social media is different than the average person's, but anything organ donation, I think, comes to like our death.
No, and
right
it was
away.
a pretty popular article across everywhere, apparently. So
Yeah, it had some eye-catching topics and some kind of, I'll say it, some clickbaity things that will get people to kind of want to see what's happening. And so we will kind of get right into it. The name of the article was a push for more organ transplants is putting donors at risk. And if you go way back to one of our previous episodes, we actually talked about myths in organ donation. And one of them I had remembered speaking about was people being concerned if like their license said that they were an organ donor, that people would not try and save them. And I feel like this article tried to like fall into those misconceptions and give it more light than I think it deserves. But that's I think where the context comes in and where more explanation is needed, and hopefully we'll do that tonight. So Alin, I think we'll both talk about this, but I'll let you get started. And one of the main topics here that I think is extremely important to discuss is there are two types of organ donation after brain death and organ donation after circulatory death. So can you try and help explain what the two differences are and why it matters?
yeah, of course. So and I'm going to be looking at my notes here just so I'm explaining everything correctly, because I'm really careful about the way I say things, because as much as people say the little things don't matter, I do think that language in this case does matter a lot. We have to be very, very clear in the way that we communicate with the general public. We have to be very clear in the way we communicate with even clinicians. Healthcare workers aren't fully aren't well versed in organ donation sometimes, which is the norm. So I guess I'll start off with kind of explaining that too. So DBD, brain dead organ donation, versus DCD, which is circulatory death. So DBD is when a patient who has been so if a patient is brain dead, in most states, that is legally the same thing as dead. And so if someone is brain dead and they are an organ donor, or they become authorized to become an organ donor once they talk to family, you are able to manage this potential organ donor based on certain criteria that makes them brain dead. And there's a whole bunch of different tests you do to make sure, but basically, you check all this patient's reflexes, you make sure that they're unable to breathe on their own with the vent. You turn off the vent for a couple, a period of time, and then you check to make sure that they're still apneic or not breathing on their own. There's usually some sort of imaging done as well. On top of that, this whole very extensive um, uh, examination that's done based on not only diagnostics, but like an actual physical exam has to be done by two clinicians, a certain number of hours apart, depending on where you are. So it's a very, very meticulous process that we are very, very careful about. And so if a patient is a DBD organ donor, that means that they have been declared brain dead two separate times by two separate clinicians. And we as the OPO are managing them in a certain way. There's a bunch of different literature on how to manage these types of donors, but basically it's the same thing as making sure their blood pressure is okay, making sure their electrolytes are okay, And this usually takes anywhere between like 1 to a few days, and then you're able to procure that organ donor's organs. So that's kind of what brain dead is. DCT is donation after circulatory death, which is basically um, what you do in this case is that patient is not necessarily brain dead, and I hate using these terms, but it's the truth. It's that they're almost brain dead. So, they may not have they have almost every reflex that they're unable to do except for like one or two. So, for example, the brain stem reflexes, maybe they're still able to cough or they're still able to breathe on their own. And so, in general, there's certain points that we look at to see who is a potential candidate for DCD organ donation. And in this case, you actually withdraw. So this patient is already somebody who is on comfort measures or, end of life care. You withdraw, you wait a certain number of minutes. So usually anywhere between 60 and 90 minutes to see if they actually, die within that period of time. Afterwards, you have to wait even an additional 5 to 10 minutes to make sure that their heart has completely stopped. And then you go back and procure organs. So, DCD is a little bit newer. I mean, it's been done years and years ago. I think one of the first, transplants was done with DCD as well. But they stopped doing them. And then a few years ago, we started redoing DCD organ donation. So they're very similar, but also very different. And the reason why it matters, why we should know kind of the differences between the two, is because this article points out some of the issues with particularly DCD organ donation.
Yeah, exactly. I would say that the articles, none of these cases are brain death cases. From everything I
Correct.
read, these are all donation after circulatory death because, like Aline said, brain death equals death. And so those patients, we know they are no longer alive and they are donors. And one interesting fact that I actually found from this article was that the donation after circulatory death was initially like thought of. I think you're very right. I think the initial transplants were done this way, but then it left. And
Sure,
but then in
yeah.
the
Yeah,
90s,
there was a few.
yeah, I think in South Africa, the first heart transplantation was technically a DCD donation. Don't quote me on that, but we could go back and look. But in the 90s, UPMC, University of Pittsburgh Medical Center, had a patient who was on life support, and the patient said, "Please remove me from life support and please donate my organs." So they followed the patient's wishes, and then after that started looking into how to make criteria for this and make it more of an option. And it really didn't take off until just recently, mostly due to medical advances in the way that we're able to preserve the organs after donation while they're being transferred to the recipient. And when we talk about this, I think the article can really talk about some of the extreme cases in these instances and make it seem extremely horrible. But there are true signs of life in these patients. So I don't think we should be like, oh, the patient was alive and they took their organs. That's not really how this is being determined. This is a patient who is determined to have catastrophic illness or debilitation. Maybe they are as close to brain death as you can be, like Aline said, where they just maybe have a few brainstem reflexes. But maybe like there's many patients out, not many, but there are some patients, for example, one that just comes to mind because we have seen this is patients with ALS who have a terminal illness, and at the end, though, they decide that they want to be organ donors and they know they're going to die when the life support is taken away from them. And so those patients are alive and making this decision on their own. And so when they go to the operating room and life support is withdrawn, we have this waiting period. And in this waiting period, when we're waiting to see if we can use their organs per the patient's wishes, there are going to be signs of life because unfortunately these patients are actively dying in front of us. And it's tragic, but it's also heroic. And we've talked about this. These are people who have made the decision or their families have made the decision to donate organs. And education here in context is extremely important. When you just say, are we putting donors at risk? There's certain things that I'll get into as we talk about this that I think we need to make sure of that are occurring for these donors because like I said, it's heroic. But if you say a patient has tears in their eyes or there was a movement of their arm, that's going to happen when people have decided that withdrawing care is in the best interest of the patient. Um, so I guess we can kind of deep dive a little bit more into this. Um, the article starts with a patient who is in a small, it sounds like rural hospital, and it is a sad story of a patient who just choked, and then died. And the way it goes is that the family must have been told that the likely outcome would be that they would have a pretty debilitated life that would be tough to live. And the family decided the patient would not want to go through that. And they decided to withdraw life support and take them off of the life support and donate their organs. The concern with this case is that the patient was then brought to the OR, reportedly 103 minutes go by, and then they decide that the patient has officially passed away, and they decide to start donation. And when they go into the chest, they see that the heart is still beating. Um, and that kind of gets to the point with, is there more education or certain things that could go wrong in cases like this in rural hospitals where DCD donation does not occur, that we need to be thinking about moving forward as we make sure this is a streamlined and ethical and patient-centered way to do this?
Right,
I don't know if you can
exactly.
answer that
So
one.
basically, no, I can. So basically, we got to keep in mind that when someone is actively dying, and me and Kobe, I mean, especially me as an ICU doctor, there's been plenty of people that I've seen, die in front of me because they've chosen to either have end of life care, or they're just very critically ill. And so when someone dies, they are going to have specific reflexes, and just because they have these reflexes doesn't mean that, I mean, it doesn't mean that they could necessarily feel there's been no studies done to show exactly what's going on in their head if you're basically almost at the point of dying, and someone tears up, or they breathe with difficulty. And so it's kind of up to the physician and the bedside team at that time to figure out exactly, is this appropriate? Should we give something to help make them more comfortable? And again, because we weren't in on these cases, it's really hard to tell exactly what happened in the OR. So, for example, with that case, but that also, there's a lot of other safeguards in place, and there should always be, so that if you feel like this patient is not necessarily dying or going to die in those 60 to 90 minutes, then in that case, you should just halt this possible organ procurement process and, take this patient back to the ICU where they can have end of life care done. And so I should also explain that whenever there's a DCD organ donation, kind of the protocol that most hospitals use is they'll remove life support, so including like ventilation, anything else that they're on. You wait the certain number of time, and then a certain number of minutes, and if they don't die within those certain number of minutes, that patient is then taken back to the ICU or the palliative care unit, or sometimes they're already in there, they don't actually go to the OR beforehand. And you just continue with end of life care at that time. And so with this case, it's really hard to tell exactly what happened, if anything was missed. But what I always say is, like, that's why there are so many safeguards in place. That's why we tell people, hey, speak up if you feel like something is not going right. If you feel like this patient feels something, or they're actually alive and they're not going to die in this time, then you have to say something. And so it's absolutely an unfortunate case that happened, but I want people to know and have trust in the system that this is not the norm, right? And it doesn't mean that it should excuse what happened at all, but it is not the norm. And, there are strict protocols that are followed no matter what. Um, we should also say that when I talk to donor hospitals, so again, I work at an OPO. Sometimes I do lectures for other doctors who aren't necessarily, well versed in taking care of organ donors or potential organ donors. I always also tell the physicians that you are going to do everything that you would have normally done. Just pretend like this patient is not an organ donor. Like, we never try to cross or have any sort of conflict based on, oh, this heart may go to a recipient that, is a little bit older. Should we get a cath? Like, no, we do not ever do things like that when it comes to DCD. You basically take care of that patient as you would had they been, just pursuing end of life without becoming an organ donor. And that's really important for physicians, clinicians to understand. And so again, in this case, like, I don't know exactly what went wrong, but the reason why there are safeguards in place and the reason why we educate physicians to make sure that they are still doing everything that they would have normally done. Just pretend like the OPO is not there, pretend like um, this patient is not an organ donor, and just don't worry about, like, if we want to make sure the patient is more comfortable and, understands, and the family understands the process more than anything.
Yeah, exactly. And just to add, in terms of like, again, I have no idea what happened with this case, but like, let's give an example of why something like
Right,
this could happen.
exactly.
And I was thinking about that, right? So a lot of times these patients have arterial lines, and meaning catheters that are in their artery in their wrist or in their groin artery, and that is showing their pressure with every beat of the heart. And the way this system works is we think systolic blood pressure, meaning that top number when you normally get a blood pressure, needs to be less than 50. And that's when you start your clock about what we call like warm ischemic time, where there's concern that the organs are not going to be oxygenated and get the nutrients they need. And in the heart trials, we used 30 minutes when this was done. And if you think about these catheters in a artery, these catheters can sometimes like be up against the artery wall, and all of a sudden that number might be what we call, and it's a stupid term, but dampened, and maybe that number is reading lower than it truly is, and all of a sudden you think you're in that time frame, and you think all of a sudden that you've hit the number, and the patient has passed away. It's not something we ever want to happen, but we're all human, and errors can occur. And then when you find these cases, if you search across the country, you're going to find cases that something like this may have occurred. And to me, at least one of the right things happened, and that's the doctors that were sent to procure these organs said, "Oh no, we're out, we're done," and the case didn't move forward, which is completely appropriate. The main thing that you would hope is that the patient never felt pain, and we'll never know that, unfortunately. And that's one of the things that I think is very important while we, as people review this, which it sounds like all these cases are constantly being reviewed, is we need to make sure that these patients are not suffering, because I'll say it many times. They're doing such an amazing act. They're saving multiple people's lives with this active organ donation, that you want them to pass peacefully without anything. And so that's one of the just an idea of why something like this can happen. The other thing that Aline talked about that's extremely important, and that the article brings up, is that when a patient is brain dead, the organ procurement organization, the groups that Aline is a part of, can help facilitate donation. They're there to help make sure that donors' organs get to the recipients. When the patient is brain dead, they know on the flip side. So as a transplant cardiologist, if we have a donor who is brain dead, we can ask the organ procurement, "Hey, are you able to get X test?" And if they think it's appropriate, they can do that. When a patient is going to be a donor, but it's circulatory death, the OPO, the Organ Procurement Organization, has no role in the care of these patients. And that's what Aline was, harping on, is very important. And that's that, as a physician, as any medical professional, you just take care of the patient as you normally would. The OPO has no role into it until the patient goes to donate the organs. The article gives the impression that that's not what was occurring. Now, we don't, we
Right.
can't say, but they make claims that these OPOs are making recommendations. Um, and that's something that cannot happen. So if I'm looking at this article of things that I think are wrong and versus right, that's one of the things that, if that's happening, we need better education amongst everyone, that they have no role unless it's a brain death donor. And I think anyone who's in this system would agree with that.
Exactly. And so just to reiterate, when it doesn't mean that, so the OPO is still there and they can technically recommend things, but that patient, and I say this when it's a DCD organ donor, I say potential organ donor, right? Because we're not even sure if this potential organ donor is going to die in time to procure their organs. We are there. We could sometimes recommend things, but in general, you're not doing invasive tests. You're not doing all these extra things on someone who is just, end of life care that's being done by the intensivist and the on-site staff. Now, again, we're going to reiterate, we don't know what exactly happened. Maybe they thought that the OPO was supposed to take over and they didn't realize, but that just shows how important education and having strict protocols in place matter. So when I am doing lectures for clinicians at our donor hospital, whether it's, doctors, nurse practitioners, nurses, the bedside staff, I always reiterate that, if you're uncomfortable, if the coordinator there says something like, hey, we need to get, an echo done. And, you would not necessarily get an echo done on someone who is comfort measures. I say if you're not comfortable doing something like that, just this is your decision. They can't put any orders in on these potential donors. But I do think that that just shows how much more, I don't know what other OPOs are like. I don't know if they have lots of education that they do with their, specific donor hospitals, but I do think that's a point that we could really, really take away from this article is I don't know how true any of it is. Some of the things I'm like, I don't know if that actually happened. We were not there. But the main thing is just education is very important for donor hospitals. And people think that we get, if somebody's an organ donor, they're going to probably be at some big trauma center. And that can happen. But in general, think of it like most hospitals in the United States are small community hospitals, rural hospitals. So these aren't people who are constantly taking care of organ donors or people at the end of life. These are doctors who maybe take care of one organ donor a year, if that. Like there are many more of these smaller hospitals that aren't used to taking care of specific types of patients, and that's where some organ donors are.
Yeah, and I think, um, kinda adding on to that is these doctors are trying to make decisions on what the trajectory of this patient's medical illness is. So, for example, if you have a patient who gets in a car accident and they're showing that they're paralyzed, okay, and they're not being able to move their arms and their legs, they don't know what the recovery is going to look like. They have to make a guess, and now people are making very educated guesses. That's why we go to training for 1,000 years. Um, and they have to go to the patient and they have to go to the family and tell them what they think. And so I find it kind of like a backhanded thing to say in the article that these decisions are just like medical judgment calls. Well, it's like they're judgment calls that are coming from very educated people who are making them, and everyone, of course, can be wrong. In one of these, the story is a patient was brought down for organ donation, and then she regained consciousness and is now fine. Yes, that can happen if you think that somebody um, it has no significant likelihood of recovery, but every so often people can get it wrong. And again, if you search the whole country for this, you will find some of these cases. Um, but that being said, is people's preference of what they want their life to look like and context matters. And what I mean by that is there's people who would be okay having a trach, a breathing tube in their neck, and a feeding tube in their stomach to live out the rest of their life, where there are other people who their family knows absolutely not in a million years would they ever want to live like that. And so that might determine if they want to withdraw life support or if they don't. And it's not rushing it if or making poor decisions. It's strictly knowing a patient's possible preference. And some of the patients, as we've talked about, are alert enough to try and help provide this information. If not, it's a lot of times families, and I don't know if we've said it on here before. I'm sure we have, but it's very important that your family knows what your wishes are if you were to ever find yourself in this position.
Yes.
And I think
Yes.
my family knows that I'm not somebody who could live stuck in a bed with a trach or a peg. It's just not who I am. That's
Right.
obvious. And so I just want to kind of talk about that because I think these stories in this article at the very face value of them of somebody who has tears in their eyes biting on a breathing tube, or somebody who's paralyzed from the neck down but is like shaking their head. There's so much more to this than a simple literally one sentence in this article is so eye-catching that I think you really need to make sure you understand how important these conversations are, and so much more nobody's getting wheeled down to an operating room in a matter of seconds for just anything. The
Right.
families are having we're having family meetings. There's multiple doctors. Everyone's weighing in. You're having
Right.
specialists and all these studies, and so um, I don't I don't have like the right way to say it other than context matters and how people would like to live their life matters.
And your own judgment, and I remember, because I'm just like you, Kobe, I was like, I would never personally want to live, with a trach, but things can change, right? I don't know, maybe in 10 years something happens to me and I change my mind, um, and your own values should never be pushed onto others. So yes, it's
Yeah,
important to be a registered organ donor, but at the same time, sometimes your family doesn't know that you're registered. Sometimes they're unsure of what that really means. And so for me, it's even more important to let your loved ones know if you'd be an organ donor. And on top of that, just know, have a plan in case something ever happens to me. I don't ever want to do this. Or hey, in case something ever happens to me, please, trach me, give me any sort of support needed because I want to live as long as possible. So just make sure your family, loved ones know your wishes ahead of time.
yeah, I agree with all of that. I think going to switch gears on you and ask you a question. You're an ICU doc. You know the answer to this. If a clinician administers morphine, will that hasten the death of someone?
It shouldn't, no. And I mean, again, dosing matters, but in general, no, it definitely shouldn't. It helps comfort patients at that time.
Exactly. And that's palliative care doctors have told me this over and over and over again when I was in my initial years of training, and it does not hasten death. It is there because there is this type of hunger, we call it air hunger, that happens as you could be dying. And so we give morphine because it decreases that sensation, it decreases pain, and makes people feel better. You don't want people to suffer. So there's a nice line in this article that says people were being given morphine to hasten death, and that is just not true.
Abs
And when we see errors like that, we should call it out. Um, I think one of the last things about this article that I think we'll talk about, and if you can give your opinion on it, that would be great. And that is, it sounds like in 2020, the HHS decided that the number of transplants would be the benchmark for OPOs. And is that the current benchmark that you're operating on? And do you feel like that benchmark is appropriate? And
So, in a way, yes. And so an OPO is and sorry, so metrics, which is kind of the way that things are measured in healthcare, whether or not it's a hospital, it's an OPO, an organization, whatever it is, a clinic, CMS will look at specific metrics that this organization, again, hospital, and any entity in the healthcare system is doing. And so one of the metrics that we use is number of organs transplanted. I mean, I don't necessarily agree with a lot of the metrics that are used in general. Like, as an ER doctor, as an example, they, measure how often you are giving people fluid boluses when it comes to sepsis, when in reality, there's a lot more nuance to it. So, as an example, if somebody has heart failure, you have to be careful of how much fluid you're giving. So, it doesn't necessarily mean that the doctor is doing a wrong job, a bad job, or the hospital is wrong in that they're not giving a certain, amount of fluids to somebody with sepsis. So, in general, metrics are very nuanced and it's hard to really pinpoint how to best measure things. However, I do understand the reasoning behind it. And so, what Kobe is asking is OPOs are measured based on, or kind of like graded based on how many organs they are able to transplant. It's kind of weird, right? Because OPOs are the in between a donor hospital and a transplant center. And so we can be at the donor hospital helping manage a brain dead DCD donor. We could be helping with coordinating where this potential organ goes, but ultimately the transplant center will actually transplant or implant this organ into somebody else. And so if something happens in between, or if, of course, some of our listeners probably know what dry runs, like sometimes at the end, something happens and the transplant center cannot necessarily transplant a specific organ that they said they were going to, for the last 6-12 hours. And so I do think that it is appropriate to grade or, look at different OPOs based on this system. because I don't know how else it's supposed to be done, but there also has to be a very good understanding of the nuances of the system because there's a lot that could happen in between the donor hospital and the transplant center that the OPO is not a part of. Although again, they do a lot of the coordinating. At the end, the transplant center will say yes to an organ, implant the organ, and so it's a difficult question to answer, and I feel like I'm being very political about it, but I'm also trying to make sure that people understand that there is no perfect way, in my opinion. So,
Yeah, totally understandable. I don't work for an OPO, and I think there needs to be some sort of either major addition or something different in terms of um, family like satisfaction. Almost like we have different uh, surveys that go out to families that
oh
grade
yeah,
hospitals, right? Press Ganey was one, and I think there's a newer one now. And I think it would be interesting to make sure that families felt like their loved one was like respected and everything along the way occurred in a way that they felt was appropriate. Um, and I swear this is the last time I'm going to say it, right? It's a heroic decision and it needs to be treated that way. And I think just it occurring is not enough. It occurring the right way, the way with all the checks and balances that go into the system is the right way to do it. And obviously, I think that's asking a lot because you're asking to try and like one, this is a lot of times happening like over in the middle of the night, and you have people like coming in, and you have families at home getting calls, and I've seen it from the recipient side of me receiving one, and then the recipient side as a physician. I've never been on the donation side other than like as a medical resident. I had a patient or two that ended up being donors, but I wasn't in it on the donation side the way that Alin is. So it's easy for me to say, a lot easier, I'm sure, to implement, but I do think it's important. And as we continue to review the system, which sounds like it's constantly being reviewed, and possibly changing as sounds like maybe more organizations are going to be starting to play a role as it's currently under a single system, which is the United Network of Organ Sharing. There may be more coming in. It's would be interesting to see with more bodies with more ability to look into making sure some of the stuff in the New York Times I don't think is accurate, and I
no.
think actually a lot of it I think was appropriately done, and it was sensationalized, but the areas where it did go wrong, I think we need to figure out how to fix that.
Yeah, and I will say that yes, I agree to an extent with the surveys and making sure that the family um was, aware of what was going on, understood what was going on, was happy with the care. But at the same time, we have to remember, and I know this as an ER doctor because, Press Ganey plays such a big part. It's usually the people who are least satisfied that complete those surveys. So who knows, in
It's so
general,
true.
if you hate a restaurant, you're probably gonna write a Yelp review, but if you love it, you probably won't. And so we have to again, it's so difficult to find the one correct answer. I do think it has to be a few things other than, one number and one survey, but at least to get the discussion going and to help people understand that there's so much more to organ donation than these sensationalized, pieces. And again, I agree with Kobe and like we weren't there. Who knows what happened? Maybe there was a miscommunication and the stuff that they're saying is correct, but there were some ways that they said some things where I was like, that had to be worded way better than that. And what we can take away from this is anytime there's any scrutiny or any negative criticism, I'm really upset at the negative impact it's going to have for registered organ donors because again, I don't think everything was appropriately explained in the article. But ultimately, what I am happy about is that this means that there is going to be changes. There's going to be more protocols in place. People know about improved communication, and hopefully, that means that things are going in the right direction.
Yeah, totally agree. And I will say nothing about this. Obviously, I'm on the inside of a lot of this, so I get to see it from that point of view. But nothing about this article made me change my mind. I would 100% still be an organ donor. I would 100% still be fine with myself or my family making the decision for me to be a DCD organ donor. And so, um, and as we know, one of the biggest things leading to the 100,000 or so people waiting for organs is lack of donors, and stuff like this I think is meant to get people to read articles and come to the websites and maybe doesn't think about the picture and the importance of organ donation as a whole. And you would want it to not set back research and everything else as we're looking into even other avenues of organ donation with through xenotransplantation, for example. You don't want stuff like that to be have negative context in the whole system. And so they take a major step back and say, we're not going to put more money into XYZ. And so
Right.
that's where I think it's easy to write an article and help out your career by making sure a ton of people read it. But there's 100,000 or so people waiting for organs right now, and they need people willing to donate.
And keep in mind, the U.S. has one of the highest like transplantation rates. How many did we transplant? Like over 40,000 last year. Like
Mhm.
that's insane, right? And so keep in mind that again, tragic cases should not have happened, but very few. These are very few cases based on what actually did go right, and I hope people understand that too.
Yeah, and I had some extremely sick patients who were in need of organs, and they were saved strictly through the act of donation after circulatory death. And so we need to have this as an avenue for people. We just need to make sure that donors go through the process the way that it should be done. And anytime we find an error, we find out why the error occurred and we fix it. The same thing we do with every form of medicine. In my job, if too much of a medication is given or something, if there's an adverse event, the hospital system starts to look into why this adverse event happened. And we try and see if there was a systematic reason, like a system based reason, and we fix it. And that's the same thing that should be happening here. And it sounds like it is. All these cases these cases are clearly known and being looked into, and that's the one true benefit of this is eyeballs are on it to make sure anything that may have gone wrong won't go wrong again in the future.
Exactly. Exactly.
So that's it for today's show. Thank you everyone for listening. Hopefully you'll check us out check us out again at our next episode in about a month from now.
Thanks for listening. I'm going to try not to butcher this, but you can reach us at both sides of the stethoscope at gmail.com. Follow us on Instagram. And of course, check us out on the podcast version and subscribe. Please share, show us some love, send us questions. And yeah, next
Yeah,
time.
and subscribe, I guess, to the YouTube channel now too.
Oh, yeah, that too.
I remember way back in the early like days of YouTube, be like you subscribe down here, right down here somewhere. I think it's still there. So
Probably.